Now, it's my pleasure and my joy. I'm Shirley Evans, I'm Director of the Association for Dementia Studies at the University of Worcester, to chair the Tom Kitwood Memorial Address. And I'm absolutely delighted to introduce Claire Surr, Professor of Dementia Studies at Leeds, Beckett University, to talk on the topic of dementia training and education, the magic wand of dementia care. And Claire's going to talk for about 40 minutes, and then there'll be an opportunity to ask questions afterwards. Thank you very much, and over to you, Claire.
Okay, it's a great privilege to be standing here to deliver this Tom Kitwood Memorial Lecture. Tom Kitwood is the reason I'm standing here today. Tom was my psychology lecturer at university, and he helped me get my position as a PhD student doing research looking at care in care homes and how that could be better for people with dementia, and that started my journey to being where I am today. So it feels a great privilege to do this memorial lecture. I'm, as I've been introduced, Claire Surr, Professor of Dementia Studies at Leeds, Beckett University. My main research areas are around applied dementia research. I'm particularly interested in care homes research, education and training, which is what I'm going to talk about today, but also interventions and how we can improve life for people living with dementia, for those who support them, and for staff working across health and social care settings as well. So, how many people have heard some of these phrases before? We tried dementia training, but it didn't work. Or, well, to put X into practice, all we need to do is train the staff and it'll happen. Or, well, I've already done dementia training. I did a course 5 years ago. People heard those before? Yep. Yeah. Common things that we hear all the time in our sector. And I'm guessing a lot of people in here do not agree with those statements, so I'm hoping that, because then you'll be with me on this journey through this presentation. The evidence base for this presentation is, many of you will have heard me talk about the What Works study that myself, colleagues from Leeds, Beckett and Bradford universities conducted, that looked at what is best practice in terms of effective education and training in dementia care. And a shameless plug for the book that I wrote with my colleague Sarah Smith and Isabel Latham, who's in here somewhere, around dementia education and training. So all of what's in this presentation comes from these two things, and it is all in the book in various guises. And everything is underpinned, and our study was underpinned by the Kirkpatrick model for evaluation of training. So 3 levels, it's not 4 levels, not saying any is more important than the other levels, but actually you've got to consider all of these things if you are thinking about impactful training and education. You've got to think about the reaction. What do people think of the training? If they don't enjoy it, are they going to go and put it into practice back in the workplace? Probably not. We need to think about learning. Do people know something different? Have they learned something? Have they got new skills that they feel they can put into practice? Have they got the confidence to do that? Behaviour change. Training's all very well, but if people don't actually do anything different, then it's not going to make a difference in terms of impact on people's lives. And then the 4th level is that impact. So impact for people living with dementia, for their family members and supporters, and for staff as well, in terms of things like burnout and job satisfaction. So those were the things we were looking at within our study. And I've heard quite a few people who've been presenting about education and training yesterday, talking about using this same model. So it's good to see that it's being used quite widely in the sector. So this is quite a traditional model. I think when I first started back, way back when, in the field, dementia training wasn't very common at all. Some providers were doing bits of it, but there was kind of a sense that people didn't really need training on dementia because dementia care was not difficult work. So there was a bit of a feel that, well, if we train staff, we recognise outcomes aren't necessarily good for people with dementia. And so person-centred care and other things could only come from providing staff with some training. So there's this idea that if we train people, then magically we will wave the magic wand of training and we'll end up with results for people with dementia, but practice will automatically and magically become better. I think we all agree that that is not quite that simple, and to simply just train staff on something about dementia is not really going to alter things. So we've been on quite a journey over the last few years. Seems like a long time ago, but then only yesterday as well. The National Dementia Strategy 2009 really started to put training and education on the agenda, and I'm aware there were strategies, policies and plans for some of the other UK nations, but I'm just going to talk about the English ones in this presentation, but I recognise there are plans and strategies for Scotland, Wales and Northern Ireland as well. So the National Dementia Strategy for England talked about an informed and effective workforce, and it was the first time it had really been put on the agenda that this was important. And it talked about core competencies, so actually what people needed to know, about embedding that across curricula, and also about commissioning training and improving opportunities for continuing professional development. So what that did was add an extra level to this. So it got us, the sector, to think about, well, it's the content of the training as well as opportunities to be trained that are important. So the idea of core competencies, embedding in curricula, it's not just training on anything that's okay. We need to think about what are the skills and knowledge that people need to deliver good dementia care. And that training just doesn't magically happen, We need to commission it, we need to provide opportunities for training. It doesn't just magic out of thin air, as there was a recognition within that there needs to be more done to ensure that dementia training is available. And that sort of targeted that level 2 of the Kirkpatrick. So we start to think about the content impacts what people are learning, what knowledge and skills people have. And from that came the Dementia Training Standards framework for England, and again there were other frameworks for Scotland, Northern Ireland and Wales. But this was the first time we'd had a sort of national, for England, set of learning outcomes and competencies and knowledge that people working right across health and social care were expected to have. So a Tier 1 dementia awareness, every single person working in health and social care was supposed to have dementia awareness, no matter what role. And then that Tier 2, that more skilled and more in-depth knowledge for people working more regularly with people with dementia and their supporters. And then that Tier 3, more advanced knowledge for people who were in leadership roles. So it's a huge step forward in terms of education and training in the sector. And what we found in our What Works study in thinking about that content, and one of the challenges for that, the Dementia Training Standards framework, I think there's something like 16 different content areas and modules. So there's awareness, there's person-centred care, there's communication, there's end-of-life care, there's working with families. All these things are really important. But one of the challenges that we found in our What Works study is actually in terms of effective content and people being able to feel confident to deliver it and to start to impact on those outcomes for people with dementia, actually having a training programme that tries to cover all of those things but not in any depth means that it's not as impactful, it's not as effective. And actually effective training covers fewer subject areas, so it's about depth and not breadth. So the challenge is, how do you get all those different topics and all the things people know into training where you need that depth on each one of them? And that, I know that's been a challenge for the sector and things people have been talking about at Congress for a while. It also needs to be tailored to the staff attending, so generic training that covers everybody doesn't really work, and we need to think about what is this setting, is it a care home, is it a hospital, this organisation, and these staff and their role and what they do on a day-to-day basis. If it doesn't feel relevant to me and what I do, I'm not going to feel I need to take that back into practice and can do anything different with it. It needs that knowledge and theory-based content, so that there's something that sits behind what people are learning, they can see the purpose to it. And obviously it needs to be clear, succinct, jargon-free, so that people can understand it. And training's carried on being a policy priority, so we saw the Prime Minister's challenge on dementia, and this requirement to more about numbers. So, we're going to hit 1 million NHS staff trained on dementia. We need social care providers to be training their staff. We're going to have the care certificates, so people will be trained on dementia. And importantly for us with the What Works study, clear evidence base on what works to provide smarter training, and that's what we were commissioned to find out in our study. So recognition that training isn't everything, that actually we need to know if it's going to be effective training, we also need to know a bit more, not just about the content, but also how it's delivered as well. What are the ways that we deliver training to maximum impact? Because there's always a tendency, if you say we're going to train X, we need to hit 1 million people, what will happen is people will do it the quickest way possible and the cheapest way possible. And that might be fine, but actually what we know from our study was that actually doesn't mean impactful in terms of people having knowledge and skills to deliver good dementia care. So what we're starting to see here is we've got the reaction, so that's the delivery. How do people feel about what they're learning? Do the methods help them to learn and to think they can change practice? We've got learning and then starting to think through about how that might impact on results. And what we found in the What Works study, and again another challenge for the sector, when you've got lots of people to train, face-to-face delivery. People want to interact with other people to learn. They want to discuss and have opportunities for interactive activities, small group-based learning. Lectures and learning alone through workbooks or online weren't impactful. And also thinking about duration, people, quick sessions didn't seem to have the impact that was needed for people to be able to consolidate their learning. So having longer sessions, maybe half a day, was much more impactful in terms of knowledge and ability to put into practice than quicker sessions. So again, another challenge for a sector where time pressures and staffing pressures and resources are limited. How do we get that balance right of what we know is most impactful versus what the sector is able to manage within the resources? And we also found about interactivity, bringing people's own examples from practice, case examples and scenarios, problem solving. So these were the things that people really got the most out of on training. So not somebody standing like I'm doing now, talking at people for 40 minutes with some slides. Staff liked a little bit of that, that's where your knowledge content comes in, but that needed to be kept to a minimum. People wanted to really have activities and things that they could use to put that learning into practice in real world ways. Now this is a slide from my colleague Isabel Latham, and her PhD was actually around informal ways of learning. And this is really important because what we've talked about so far is, we kind of think of learning in health and social care happens through formal training. But what you can see over there is formal training actually was only a very small part of how people learnt, and her study was in care homes. I'm hoping I'm going to do it justice trying to describe it, but what the key thing was is for people day to day on the ground, they learn every day. Every day is learning in that context because they're in practice, they're working with people with dementia, they're working with their colleagues, so they're learning on the job every single day. And the key thing that drives learning is what works. So what works for that person at that moment in time is what I'm going to learn to do next time. So it might be you see results for that person. I try something, Dorothy's distressed at the door, and I try something, and that seems to work, so I'm going to try that again. It might be being thrown in at the deep end. Dementia care is not a predictable scenario. Every day you see different situations and different things, and something you tried yesterday might not work again today, so people are constantly having to try that. And this negotiation of conflicting pressures. You might want to spend 20 minutes with Dorothy at the door, but actually there's a call bell going off for somebody in their room who needs help. There's somebody sitting in a chair in the lounge who's calling out distressed. How do you manage those competing pressures and what you know will work for one person and the demands? So there's all these challenges on staff all of the time. And that's also impacted by these green things. Personal resources, what knowledge and skills do I come with? What are my values? Staff have often worked in the sector for a long time, even if they may be new to a particular care home. So they come with a lot of knowledge and skills that they will apply. They get feedback from residents, what works for that resident. And that might be different for each person. And then there's a care home culture that says, what works and what's important, and what is the thing that I'm expected of in my job. So if I'm told by the care home that what is important is getting my jobs done quickly and having all the residents up by a certain time and these things around processes, then that's what I'm going to prioritise in what works. When I've got to make that choice about, do I go and spend 10 minutes with Dorothy at the door, or do I go and do these other jobs as well because they'll be what's valued, you know, how quickly have I got through my tasks for the day, that's what I'm going to go and do because that's what the culture values. And also there's these interactions with colleagues, so people are learning every day from their peers. You know, they're asking questions, they're shadowing, they're working things out between them. So this forms part of that culture within a care environment. So it's not a complex thing, that a simple system where you put some formal training in and you're going to magically wave that wand to improve care practice. Because if you put that training in, there's still all this complex system that's going on behind everything on a day-to-day basis. That means no matter what that training's saying, if it doesn't fit in with the culture of what your colleagues are telling you and the environment, you know, the culture of the setting, and it conflicts, staff are never going to be able to put that into practice. So we start to get a bit of a longer string of things we need to think about. We've got to think about the content, the delivery methods of formal training, but also understand that staff training is both informal and formal learning that goes on. And then we've got to think about how we implement it, both how we get staff at formal training or how we implement better informal learning, but also then how staff can put that into practice once they get back into the workplace. So I'm going to talk to you briefly about something called implementation science. It sounds very technical. Some people may be familiar with it, others not. It's used very much in intervention research, so where we might be trying out something new in an environment or a setting, and we think about how we're going to make it work in practice. It's not being used so much within the training context so far, and this is something I'm interested in and that we applied within the What Works study. One of the things we looked at was it's called the COM-B system. So this is about individual behaviours. So thinking about our Kirkpatrick pyramid, it's that third level. How do we change individual staff behaviours in practice? And what we can see is staff behaviours are influenced by an influence, capability, motivation and opportunity. And motivation is influenced both by people's capability and their opportunities. So I'm going to talk through each of these individually. So thinking about capability, this is about people's psychological capability. So do they have the understanding, the knowledge, the reasoning skills to feel capable and competent to put that into practice? So have we given them the skills and knowledge they need? And then there's a physical capability. So that might be physical functioning if it's a particular task they need to do, or it could be practical skills. And these are things that we can build into training. So obviously training is designed to give people the knowledge, skills and understanding. We just need to make sure that content's right and the delivery so that staff feel that they've got that competency and capability. And again, the skills, you know, if we can build some practical skills development into training, then people are going to develop these things through what we provide. But that also comes in that informal context as well. They're learning that on a day-to-day basis. And in our What Works study, we didn't find capability to be a particular barrier, and that's because people had had dementia training. We were looking at case studies where they'd really managed to implement dementia training into practice, so people had good experiences of training. So people felt interactive learning and experiential learning were really helpful. They felt capable and competent to put that learning into practice. And where they didn't, it was because they'd been given kind of individual training to just work through either an e-learning programme or a booklet, and they didn't feel they'd been able to take, maybe learn or understand it, but then apply that into practice. Motivation. So there are two types of motivation, reflective and automatic. So the reflective motivation is people's thought processes. So thinking that something needs to change in the first place, we're not going to change our behaviour and do something differently if we think actually what we're doing at the moment is fine. Why do I need to change? So people need to see that there's a reason to do something differently and to change what they're doing. And they also need to have that ability to plan. So how can I change what I do? Is it clear to me that there's a clear way that I can do that that seems achievable and understandable? And then the automatic motivations are our sort of intrinsic personal values, our beliefs, our drivers to change. So those personal individual motivators. And again, these are things we can build into good formal and informal learning approaches. We can try strategies within training programs or within day-to-day practice that can help staff stop and think, actually that's not right. That's not great for our residents or the people with dementia that we're supporting or the patients in the hospital. That's not working for them. We need to do something differently. And we can also, through training and practice and informal learning, help people think, how can I do that differently? So particularly formal training can be useful for that because it gives people that space to learn something new, think of strategies and how they might apply them in that context of talking about it with colleagues, practical activities and exercises where they can try it in a sort of safe environment of the training room. And we can also, we've seen a lot of training develop around empathy building and trying to understand things from the perspective of the person living with dementia. So that starts to tap into those emotions and feelings and people's personal desires to want to change practice. And again, in the What Works study, we found motivation was generally a facilitator. People felt motivated to do things differently in practice. And the things that really helped were having a skilled facilitator who made learning memorable and made people want to put this into practice. And peer-to-peer learning, so seeing one of the examples here of colleagues talking about scenarios used within the training session and going, oh yeah, we see people that this happens to all the time. It made things real and they could see that there was a need to change things because other colleagues were saying this was the reality for their practice. And personal values as well. So we did get some people saying that, I did dementia training 10 years ago, do I need to do it again? But for the most part, people really enjoyed going on training that was helpful and useful to their job, and they valued it. But opportunities, and this is where the challenge comes in. Opportunities are physical, so the resources like financial, time and human resources. And then there are social opportunities, so that's the culture within a care environment, the social norms, and whether change is supported. Can we train these things? No. These are things we've got to think of outside of a formal training session. This is this bigger picture that we've got to think of around implementation of training. We can't just wave the magic training wand and expect the opportunities for people to implement training in practice to magically be there. We've got to do some work in the background. So I'm going to talk a little bit more about another implementation science model that can help us think a bit more about that. But opportunity was very commonly identified as a barrier within the What Works study. A lot of the settings had put training into practice, and so they thought this through, and particularly management and peer support were real facilitators. If their manager supported them and they felt their colleagues did and they were all moving in the same direction, then that was much easier to get what they'd learned into practice. But as you can all imagine, the main barriers were lack of resources, competing demands, staffing issues and turnover, and a physical environment that didn't allow them to do the things they wanted to do. And the quotes here also around, a supportive management and leadership within the organisation. This was crucial. So this is another framework that picks up more on the background. It's called the IPARIS framework. And what it thinks about is the innovation, so that's the training itself. And how well does that training fit with me and my setting? So, is it clear? Is it something I understand? Is it compatible with existing practice? Or does it feel like this is something so different? How are we ever going to put this into practice? So people need to see kind of incremental changes often, rather than thinking, we've got to change everything in one go. Does it feel usable? Is it something I feel I could put into practice? is it going to be better for me or for the people that I support? Can I see a benefit to doing this? Is there a chance to try it out first and to see things, observable results? So that's where things like practical opportunities within training and experiential learning can give people a chance to practice things in a safe environment. So that's thinking about what we're offering people. We have to think about the recipient, so that is beyond that individual behaviour change to the group of staff that we're going to be working with to deliver training. So some of these things are the same as in the COM-B model. We've got motivation and values and beliefs and knowledge. But it does cover the resources. Have we got the resources in this team, the support and the networks to do this? Have we got that local leadership? And does staff feel they've got that authority to actually do something different? Or do they feel their roles are quite restricted and, you know, well, am I allowed to make mistakes? Am I going to get told off for doing something different? And that's about a learning culture and that environment that says staff should have that freedom to try different things. They're not going to get into trouble for doing things differently, but actually this is embraced. What we want people to do is be innovative, to deliver good, innovative care that meets the individual needs, rather than just sticking to this is what we do because this is what we do. And then there's the context, and I'm going to come back to this in my last slide. But central to the IPARIS framework is facilitation. And I think, again, yesterday I sat in the Dementia, in the care homes stream sessions. There were a lot of presentations about different providers who've been having really successful implementation of larger programmes of training. And one of the things that was key through all of those was development of facilitators and investing in those people who were going to facilitate the learning and development and implementation to give them the skills they need. And one of the things we did see in the What Works study was often people who were really good clinicians, who, you know, were great leaders out in practice, were just suddenly told to go and deliver some dementia training, as if training and facilitation skills were just something everybody had and didn't really need any thought. And that put them under huge pressure, because then how, as a practitioner who's never delivered a training course before, do you put together something that's going to do all those things, you know, be interactive and have the right content? And it's a skill, and people are often left to develop things that were beyond their sort of knowledge base. So we've got these levels of facilitation from novice to expert, and we need to think about how we develop our facilitators, because this is not easy, leading implementation of training and then into practice change. It's a big job, it's complicated, you've got to think about all these different things. So to do it well, you need the skills and resources and the investment in you. So just thinking about the context briefly, some of these things are much more in our control than others. So if you think about the local or the team context, these are probably the things that might be within most people's reach to think about. So leadership, I've mentioned that a few times. We found this in another one of our studies where we looked at dementia care mapping, its implementation in care homes. The care home manager was key to whether homes were able to put DCM into practice or not. If they weren't on board, if they didn't have the skills, even if they said they were at the start of the study, you wouldn't sign up to take part in a research study if you weren't, but actually who were really able to drive that change, then the care homes weren't able to put it into practice. We've got the culture, and I think Izzy's PhD diagram shows us just how important that broader culture within an environment is in that informal learning process. There's people's past experiences of practice change. So they've been through this, we tried dementia training, it didn't work. Oh God, here they are with another dementia training programme that's not going to work. So people are coming with that experience of the past that we might need to work with. Mechanisms to embed. So, you know, this idea that we put X into practice by just waving the magic training wand, rather than actually thinking, what do we need to make this work? And evaluation and feedback. People need to know that what they're doing is working or not. So they need that evaluation and feedback cycle. It's no good just doing the training and expecting people to, you know, do I know if it's working? Does it make a difference that I'm making all this extra effort or doing things differently? So we need to build the evaluation and feedback into part of the embedding training programme. Some of you will have organisational roles, or you need to speak to people who have these to think about how this becomes a priority in the organisation. It needs that senior management support. It has to come all the way through an organisation to say this is important, this is a priority, this is what we see we want to invest our staff and our time in, this is what is important to us. And there needs to be the structures and systems and capability and capacity embedded within the organisation as a whole to help this happen. And then it's the external drivers, and I think we recognised from yesterday, talking about the major condition strategy. We had dementia training as a priority area for quite a long time within our policy. That's kind of dissipating now, and dementia is seen as business as usual from the powers that be. So we don't have that policy driver that we did before. We do have regulations, we do have CQC and people like that who are asking, have you had training, how are you putting it into practice? So that is a bit of a driver. But what we do have here, all of us, is this networks and relationships. What we can do as a collective is say, this is not good enough. What we recognise as a sector is that we need to be doing these things. You know, it's not a race to the bottom to train as many staff as quickly and cheaply as possible to tick the box that we've done dementia training. But that's not good enough. That doesn't change practice. What we can say is people with dementia, their supporters, care staff, deserve better. They deserve good training, they deserve preparation for their role, they deserve skilled staff who have the time, skills and resources to deliver good care. And this is what we say as a sector we need to do to deliver that, and this is how our organisations are doing that. So we do have some power here. That's what this Congress is all about, power in the room to say what we feel, even if the powers that be are not listening. We all are. So in summary, we've got a strong evidence base around impactful training, design and delivery in dementia care. We know it's not enough to just commission and deliver training and wave that magic wand and suddenly practice will be better. Training isn't that quick fix that suddenly leads to positive outcomes, but we've got to have this whole systems approach. We've got to consider individual staff and their behaviour change and how we provide good training to them. We need to think of our setting and our organisation and our teams and the wider barriers and facilitators that are offered and how we can overcome those. And that has to be planned in from the start. It's no good just embarking on a programme of training and going, oh, nobody's really doing anything different in practice. Well, they won't do if we don't build this in from the outset. And what that needs is strong leadership and good facilitation to help it happen. So another shameless plug for the book, if that's whetted your appetite. All of this is in the book. There's chapters on all of these different things around implementation science, around evaluation. There is a use that code online and get 20% discount from the link there. But there is, after this plenary, stay in this room because there is going to be, see people are taking pictures, I can't move my slide on now. Wait for it. There is in this room going to be a launch of the full book series. So there are more books in this series that are on the next slide that I will show you when people have stopped taking pictures. But this is book sales, so you know I need to make sure everybody gets their chance. So yeah, there's going to be a launch for the whole series so that you can find out more about this book, but also about all these books. And also Dawn and Keith and Chris are in session 6.4 in room 127. Later today again talking about the book series and how books like this can hopefully change the dementia care field through putting evidence-based practice in accessible ways and formats. So I've not done bad in timing.
Really good. Sparkling. Thank you, Claire, for an absolutely fantastic Tom Kitwood Memorial Address. And you have very generously shared your expertise and knowledge with us all and your reflections. And you've given us tremendous inspiration and help us to move forward individually with our own work and as a dementia community. As you said, there is power in the room. You can feel it, can't you? So absolutely fantastic. Thank you. And there's going to be questions for 10 minutes now, so we take those.
Beckett, waving frantically.
Thank you very much. That was a brilliant memorial address. Thank you for that. I was just wondering, Claire, have you done any research, or are you planning to do any research about the impact on good training and in terms of the market forces for, particularly I'm thinking care homes and home care provision? Because if we can't influence it too well at the moment, the politicians, we can influence the market. And obviously, if you do great training that has a good impact and changes the lives of the people who work in that sector, as well as the people who are receiving the services, that must have a good impact on the business, because people want to come and live there, want to use that service. Have we got any evidence of that?
Not that I'm aware of, and I think it's something I'd love to think about how you would do, but I think the challenges are it's because it's that complex system. So thinking back to Izzy's diagram, the training bit is only part of that. There's like what's going on with the other staff and the organisational factors. So it takes quite a bit to unpick where the training fits in. It's part of the jigsaw puzzle. So I think there's a bigger picture of what makes a high quality provider that will influence those market forces and what are the things they should be investing in. So it might be formal training, it might be more work on the ground, it's how do you get that culture right, it's investment in the leadership to lead that change and the facilitators. So I think there's a bigger picture beyond just a good training course that is quite difficult to unpick in a research project. It doesn't mean it's not bubbling away in my head about how to potentially do that.
Hi Claire, good morning. I'm just thinking, because you have mentioned about tailoring the training and also looking at curricula. In terms of internationally educated nurses, is that being looked into, the gaps in their knowledge? Because as an internationally educated nurse myself, I know that there are gaps in the knowledge in terms of looking after patients or people living with dementia.
It's a really, really good question, and I know it's one that I'm not sure whether there's any research done on it. It's certainly something we've heard from the sector already when we've been talking to care home managers that we've been doing a programme of training with around how, even just how we induct international nurses and staff into, when they arrive in this country, how do I even learn about the care system, and how do things work if you arrive and then suddenly you're thrown into a care home? So I think there is broader work going on generally around international recruitment, and but I don't think necessarily specific to dementia care. But it's not my specialist area, but it's a really important one. So sorry I can't answer more specifically.
Hi, I'm Sally Knocker from Meaningful Care Matters. It's an amazing presentation. And the thing that really stuck with me was that thing around it's about depth rather than breadth. That's my sort of take-home piece, because you're right, that dementia standards framework is, the 16 subjects and trying to race through them all, and certainly my focus is a lot more on depth, I hope. I just wondered if you had any thoughts, if you did have one impactful day, what would it be? Because from my experience over sort of 25, 30 years as an educator, the most impactful day I could do, if I was only given one day, was to give people experiences of doing an observation of people in a care home. Obviously, dementia care mapping is one thing, but our particular tool at Meaningful Care Matters is the quiz tool, which is kind of easier to learn for laundry workers, care assistants, and just giving people an hour observing what it's like to be in that space is the most impactful training I've never seen, and changes that come as a result of that 1 hour observation and the reflections and action plans after it is the one thing I would say has been the most effective thing. I wondered if you had thoughts on that.
Yeah, I think, it goes back to what do people need to learn. So it depends. You know, I think a training needs analysis is really key. So it may be that if you've got one day, but actually, you know, staff don't, you know, one of the things that's happening is people don't have good nutrition and hydration, and that's a priority, then that would be the priority for that day, and that one day might be different each year. So I think there's a prioritisation process, but I do agree around the observation because it helps you pick up on so many things. And actually I've been working with Dawn and a group of international colleagues on a tool called the Person-Centred Observation and Reflection Tool that is exactly that. So we have got a paper out on that, and we'll probably write an article for JDC soon on it. But it's designed to do just that. It's for every staff member. It's really easy to use. It's a 30-minute observation followed by reflective questions with a coach, a port coach, so they can think about what can I do differently. So what's the one or two things next time I'm on shift I could do differently. But also it helps feed into care planning. So for the person I've observed, or 2 people or 3, what's something I'd like to feed into their care plan that other staff could learn from, so that care plans then are not those detached things that sit somewhere that I've nothing to do with and don't feel relate to what I do on a day-to-day basis, but hopefully become more live documents that staff feed into regularly. So that's something we've been working on. So yes, we're on the same page on that one.
Yeah, I've been involved with a number of other people in helping to deliver training from the point of view of a person with dementia. And I found that the hospital staff that I've worked with have found it the most helpful training, the most insightful training that they've received. And I know that some of the projects I'm working with to develop new courses are including increasingly people with dementia as, let's say, part-time tutors, doing films as part of their resource. So I think the more that can be done, the greater the useful effect.
Absolutely, I fully agree with you on that, and certainly in the What Works study, that they were some of the most impactful. It shows in Izzy's model they're getting feedback from people living with dementia that staff are working with, and it is embedded throughout the book, another picture of the book, but we do have that embedded as a theme right throughout the book, how people living with dementia can be involved in all aspects of design, delivery, evaluation of training, because it's so important. And it wasn't being done enough at the time when we know things have moved on considerably. You know, we started the study in 2015, I think, was it, Jan? It was a long time ago. So things have moved on a lot, and that's one of the areas I'm pleased to see has, but maybe not enough just yet. Did we have one last?
Yeah, just one. Jackie said. So my name's Katie, I work at the Acute Trust in Surrey. So we very much do look at evaluation. So we run a sim day all day, so we do training in the morning, and then nurses get an opportunity to attend the simulation sessions in the afternoon, which is particularly good for our international students. But we do an evaluation at the end of that, but we also look at the inpatient survey results. We look at our incident reports to see if there are any trends from that. We have contact with our PALS department to see if things are coming up relating to dementia care, or where are pockets of concerns. We do that from a trust point of view. When it comes to our international students, we very much spend a lot of time with them. We empathise, because obviously coming from another country, it's a different type of care. Obviously the language as well, so think quirks that we use in the hospital setting, like patients might say, I want to go and spend a penny, they don't know what they don't know what that means, so we try to empathise as much as possible, and particularly in a very stressful situation when maybe someone is trying to leave the hospital, we try to empathise with the students and the staff to acknowledge that if you're having to try and then think in your first language, then obviously trying to convert that into English and trying to help someone who's very distressed at the time, we try as much as possible to acknowledge that and to give them some strategies to help, because we do have a lot of international nurses that come and work at our trust. So
Yeah, it's really important, isn't it? I think communication, when people's communication abilities are affected by dementia, it can be hard for us to understand what somebody's trying to communicate. If it's somebody trying to do that in a second language, that's even more difficult, and those barriers can break down. So I do think there needs to be much more done around, there's another idea for a research project, around international staff and how we can support them. As well about Congress, I've got projects now to take me for the next 10 years that I can apply for. Thanks to you all.